I'm Marlene Wallach, and welcome to today's FACE IT podcast. October is Breast Cancer Awareness Month, a time for education, empowerment, and action. And I'm proud and pleased to be joined today by one of the country's leading breast cancer surgeons, Alisan Goldfarb, who has spent a career in the operating room saving lives and as an advocate for health and wellness in the community. So, Dr. Goldfarb, I'd like to start with a question about prevention and risk, and that is, what are the biggest misconceptions about breast cancer risk factors, and what can women realistically do to lower their risk?
Well, there are some things you can't do anything about. Who your relatives are. Mm-hmm. If you have a strong family history and nobody's been tested for whether they have one of the genetic predispositions, then whoever had the breast cancer in the family, hopefully they're still alive and well, should have the genetics, and hopefully that will be okay. If they have one of the high-risk genes, then you should absolutely be tested.
Which are the high-risk genes?
The very high risk is the BRCA. There are several others which have lower, but there's a long list of them.
But it's the BRCA that we know of. That
if you are unlucky enough to have inherited the BRCA gene, you have 70 or 80% chance of getting breast cancer in your life.
Wow. So what do you do?
That depends on who you are and how you feel about it. There are some people that really would like to avoid doing big surgery because certainly doing a bilateral mastectomy, removing all of both breasts, which can be reconstructed by a good plastic surgeon, and it can look fine, but it will never be your breast. If you are not interested in doing that, then you will have to upgrade your screening, which means that you would start screening 10 years younger than the youngest relative who had it, and you will screen multidimensionally. You will get a mammogram and an ultrasound and an MRI every year.
Wow. You know, knowing that I was going to meet with you today, I had my mammogram yesterday.
Bravo.
Yay.
Bravo.
And there was something a little disturbing that happened. Although, you know, I'm always when I was diagnosed, it was through a routine mammogram.
Of course.
There's always anxiety when you go.
Even if you haven't had a prior diagnosis, I think there's always anxiety because you know why you're having the mammogram.
Right. But something that happened concerned me, which was that they asked me if I wanted to pay $40 extra to get an extra layer of analysis on my breast cancer mammogram.
I
So
don't know what they were offering you. There are the standard mammogram, and there's a diagnostic
yes,
mammogram.
it was the diagnostic, and all I could think about was, I'm happy to pay the $40, but
What am I getting for it?
and what if I didn't get it? Like, what about the people that can't afford to pay the $40? What is that about?
People who have very see-through breast tissue. What am I talking about? Oh, I'm so glad you asked me that question. The glandular tissue in the breast, that's the tubes and the lobules, the milk-making portion, are a little bit dense. Everything else is fat. So the difference between a woman who has a big breast and a little breast is only how much fat is in between the lobules and the ducts. So if you have a very small breast and are premenopausal still, your mammogram may be very difficult to read, and a diagnostic mammogram may be better. And they may even then scratch their heads and said, well, maybe we should get a sono too, because we don't see these little patches so easily. So it is very variable.
That's interesting. Very interesting. The guidelines on mammograms and self-exams sometimes vary. What's your
And
advice?
change by year.
So what's your advice for women of different ages?
I really think that self-exam doesn't cost anything, and the more you're doing it, the better you get at it. What is a self-exam anyway? You are taking 2 or 3 fingers and just pressing your breast tissue against your chest wall, looking for lumps and bumps. You're doing it very gently, looking for lumps and bumps. If you feel a lump or a bump, don't panic. Just show it to somebody else. If you're still menstruating, you should examine yourself 5 or so days, 4, 6, doesn't matter. When you're before your period, that's when your breasts are the lumpiest and weirdest because there's a lot of fluid held onto. After your period comes, and some people don't notice the change that much, but the ones who notice. The breast gets a little smaller, a little softer, and that's when you want to examine yourself. I don't care how many lumps you have when you're premenstrual. You got to wait and feel postmenstrual. And that's usually about 5, 6 days after your period begins.
Okay, well, that's important.
It is
That
important.
is important.
Yeah.
Well, you talked about this, how important genetic testing and when should someone consider it, and I think you gave us a good explanation of that. Now, in advance of treatment, what are some of the most exciting advances in breast cancer treatment you've seen recently?
I don't know that there are a lot of advances in treatment. I think that if you are unlucky enough to get a bad breast cancer, the chemotherapeutic agents they're using are much more successful. What's a bad breast cancer?
Yeah, definitely.
The more aggressive. Cell types are different. Breast cancer has 2 major types. Of the major types, there are 2. There's a non-invasive and an invasive. So there's ductal carcinoma in situ. That's cells haven't learned yet how to break out of the duct and therefore don't know how to spread. So local treatment is generally enough. And there's invasive. Invasive means even if you can't prove that it's traveled anyplace, you have to assume that cells could have. So that has to be treated a little bit more aggressively. Then there is lobular in situ, which was misnamed because it's not really cancer yet, and invasive lobular, which invasive lobular is another kind of breast cancer. It's very similar to invasive ductal, and it's treated the same way.
Interesting. So now,
and local treatment, generally, if it is an invasive cancer, the surgeon will want to do either a lumpectomy, meaning you remove the whole area of breast cancer, and have the pathologist, after he has it set in, wherever they set it in to look at under the microscope, the edges. You want to make sure it's all out because you can't feel microscopic edges. So you want it out with the clear edge. If you have chosen that you don't want to worry about that breast again, or are told it is either too large or there are too many spots of it, and you need a mastectomy, then that's removing the whole breast. Either way, lumpectomy, the surgeons who do lumpectomies are usually pretty good, very good, at putting the rest of the breast back together so it doesn't look awful.
it's the breast surgeon, not a plastic surgeon that
If
does
the
that?
breast surgeon thinks it's in a spot where it would be difficult to do, or it's just too big for the breast surgeon to feel comfortable, then certainly a plastic surgeon can be invited. It depends on where it is in the breast and how big it is. But to put a relatively small lumpectomy together should be in the bag of tricks of every good breast surgeon.
To put it back together.
Yeah.
Well, I guess this is the part where I say...
Oh, and did I mention lymph nodes?
No. Well, you did, just briefly.
Yes. If the cancer is an invasive breast cancer, this goes for lobular and ductal, it has the ability to spread microscopically. The place where it would be most likely to be picked up would be in the lymph nodes, because it's their job to filter the blood system and the lymphatics channel that are from that area. And the lymph nodes for most all of the breast are the lymph nodes under the arm.
Right.
Now, in the old days, when we found breast cancer late, they would take out a zillion lymph nodes, which would give you a high risk of having a swollen arm later. These days, when breast cancer is hopefully found quite early, you want to get the first lymph nodes in line. How are you going to know which ones are the ones that drain that area? Mm-hmm. This was a major breakthrough. It was a while back. But you put a little dye in the area that you can read on whatever mechanism you're using for that dye and find what is named the sentinel node.
Right.
The first one in line.
Right.
Sometimes there are 2 or 3. There's usually only 1. And that's the one that has to come out.
Is that during the surgery, or is that before the surgery that you do
The dye
that?
is put in before,
Right. So
depending on what dye they're using.
Mm-hmm. Mm-hmm.
And you can't have results for several days because it's a microscopic diagnosis.
Wow.
So there are some patients that are advised to go back to have more lymph nodes taken out. There are some who choose to add radiation therapy to the lymph nodes. You have to hope that your lymph nodes are clean. It's easier that way.
Right. Well, I think it's, before I get to the next question, I think it's appropriate for me to say that Dr. Goldfarb was my doctor. And when
It was a few years ago.
It was a few years ago. Interestingly enough, talking about a few years ago, I am in my 70s, and this was when I was 40. Back then, having breast cancer was like this. Now, it's a badge of courage.
I think there is a big change in how we look at disease of many types, not just breast cancer.
Yes, but as an advocate, as someone who actively is in the community advocating for self-care, the difference...
And here you are all these years later.
All these years later, it's over 30 years later, when Dr. Goldfarb asked me if I wanted to have a lumpectomy or a mastectomy, and I said, I want a mastectomy. And she said, how'd you get so smart? I always remember that because...
Well, for those of us who are not sitting in the chair you were, we worry about the risk of there being small areas outside the location.
Right.
And nobody can tell you that until the pathologist, once the tissue is gone. And the plastic surgeons are pretty good at reconstructing something that looks very much like a normal breast. Unfortunately, the sensation is not there. Now, sensation in the breast is something that varies a lot from person to person. When I used to have the discussion with my patients, sometimes they go, "Ah, no sensation in my nipple? Oh my God, I can't do it." And then there were those that would say, "Sensation?" Sensation. So people vary.
I think I said, who cares about sensation? Just get it off. I don't want any problems. Has that changed for you? Have people's willingness to have a mastectomy, is that a greater percentage than it used to be?
I think it's changed a lot. I think the unfortunate thing about finding breast cancer is there are still many, many women that don't screen.
Yeah.
And that's a desperate problem. Because by the time you will notice a lump,
Then,
and excuse me, how many doctors that are general practitioners or internists are doing breast exams when you go to your doctor for a routine checkup? Does he or she do a breast exam?
right. Not really.
No, mostly not at all. Mostly not at all, which is horrifying.
Yeah, so what you're saying is as much as we've gone forward, we haven't, so to speak.
Listen, breast cancer is a common disease, but it's not desperately common unless you're in one of those families. What is the overall risk of getting a breast cancer? If you had no knowledge of your genetics and said, just give me a wild guess, probably 12%.
Wow.
It's not an enormous risk, but it's real.
Well, there was no breast cancer or cancer in my family.
And you didn't do anything to deserve it.
Right.
There aren't very many things you can do to deserve breast cancer. It's not like lung cancer and cigarette smoking.
Right. 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 Now, as a surgeon, how do you balance the clinical side of treatment with the emotional and psychological side? I mean, that's a statement that could take...
That's changed enormously because medical care has changed so enormously within the last 5 or 10 years. I'm not going to say a word about the insurance companies, but it's because you don't really get paid much anymore for doing anything. And private practice is gone, and you're working for an employer who generally wants you to see a new patient in a relatively short amount of time.
You mean like every 6 minutes kind of thing?
I wouldn't say 6. I don't know what they do for the new patients, but I know the follow-ups are 10 minutes. And I don't think that's enough time to do any. I don't call it psychological, but have any warmth, any conversation, any guidance. And I think for me, it was a very, very important part about being a doctor.
And I remember, I mean, aside from her being my breast surgeon, she was also a friend of the family.
Her older sister's best friend.
My older sister's best friend. So it's fair to say that when I called her crying the day I got home from the hospital, she actually came over. I mean, I still remember that. You know, I'm sure you've changed the lives of many people that you never even hear about. But
interestingly enough, I still get cards from people who have moved far away, who I haven't seen in a gazillion years. And
wow.
I'm very touched by it. I mean, I'm very lucky that I didn't try harder to do it well. It's just my personality. And
yeah, and the interesting thing is you're kind of a tough love gal, but when it came to that, you were patient. There was no tough love involved. It was all about caring. Yeah. And for that, I thank you at a very, at a very deep... Oh, I have an interesting question, and I don't know. I just thought of this. Knowing that you were operating on Leanie, me, Did you feel an increased responsibility, or was there
I
something?
feel an enormous responsibility with every single patient. Now, would I have operated on my own sister? No.
Right.
No.
Right.
I barely even talked to my
How,
mom.
I was going to say, how is she?
She's lovely. What am I going to say?
Okay. Okay.
Not that she'll ever hear about it. She was pulled to Sedona, Arizona by the magnetic fields years and years and years ago.
I
And
see.
now when she complains about the weather, if I said to her, you were pulled there by the magnetic fields, she would ask me if I was insane. So she's an unusual person.
I remember that about her. I definitely remember that about her. What else can I say? Family, equity and care. Do you know that outcomes differ? I'm not talking about ingoing. I'm talking about outgoing. Do the outcomes differ from race, income, or access?
Oh, of course. Of course. If you don't have access to medical care, you're not going to be seen as early. And if you don't have insurance, I'm not sure how you're even going to have your medical care. It's a real challenge. This country, it's a real challenge.
Now, this almost seems like a redundant question, but does lifestyle, nutrition, etc., enter into breast cancer?
Sure. Enters into everything. Being lots and lots overweight increases your risk of breast cancer. It also makes it harder to find.
Wow, that makes sense.
And I don't know whether the exact dietary intake, but you need the diet that's going to make you extra fat. Alcohol. There is a slight increased risk of many kinds of not just breast cancer, many kinds of cancer with a significant alcohol intake. And
Really?
a lot of us don't know exactly what to say about alcohol intake. I think 1 drink a day isn't so terrible. 2 drinks a day, I shouldn't talk. It probably still isn't dreadful if it's wine, but if it's hard liquor and it's more than a drink a day, it's dangerous for many diseases, not just breast cancer.
Now, is there a difference?
But it's not close to smoking and other diseases.
Okay. Is there a difference between breast cancer in men and in women?
Not really. Not really. It's much less common because so many of the breast cancers are hormone dependent. So if there's much less estrogen, there is less risk of an abnormal cell that is a cancer cell thriving in a man.
Right.
But it exists. It's not desperately uncommon. It exists.
Have you operated on men?
Oh, yeah. And more lately because I have a part-time job now at the VA.
Right.
So a large proportion of my current patients are male.
Wow.
I would say I've done more mastectomies in the past 5 years than I did in most of my practice.
Really?
Sure, because of the population.
Wow. So what, as someone that's been doing this for
Don't tell me how many years. I don't want to hear it.
who has a mature practice.
Yeah, I'm practically retired.
What can you say to a 35-year-old?
Number one, she should have a good gynecologist, whether or not she's planning to have kids, and a good internist. Depending on her family history, she should start having mammograms. I think the guidelines now say 40, but
they're back to 40.
I favor 35. Is that what you read?
No, I was just 40, diagnosed in a routine mammogram.
Yeah.
Just 40.
No matter what your risk is, you should be having mammograms. Because even if your risk is 10%, it's a bad disease if you don't find it early. If you find it early, Although the treatment is often not delightful, it's usually successful, which is a lot better than not successful.
Well, now that we finished the formal part, I could
we
call
did.
you Alisan.
Well, you
And
could have anyway.
I could, well, out of respect for your
Well, I've
professional.
probably known you since you were a teenager.
8.
8? Oh, excuse me.
8, and you were 13.
Oh, my. Oh, that's right. Eighth
Yeah.
grade. It was 8th grade.
That's right. So there you go. So I want to thank you so much for this conversation.
You're welcome.
And I wish you all the best of luck in your career and in your life.
Thank you very much.
Thank you, Alisan.